provides an overview of the vestibular system as well as some common diagnoses that you might see in patients with vestibular dysfunction. It's common practice as an outpatient vestibular therapist to be given a script from a physician that says, treat for dizziness. Well, before you can treat the patient, you have to figure out what's actually causing the dizziness. And in general, there are three main causes from dizziness that are listed on this slide. The first is the otologic system, and this has to do with the inner ear and the vestibular system, and we'll go into more detail about this throughout the PowerPoint. Causes of otologic dizziness include BPPV, vestibular neuritis, perilymphatic fistula, as well as Meniere's disease. And again, we'll be talking about each of these otologic causes in more detail at the end of the PowerPoint. The second main cause of dizziness would be neurologic. This could be due to vertebro-basilar insufficiency, a stroke or TIA, a migraine, or low cerebral spinal fluid. And the third cause would be a general medical cause. Could be a deficiency of B12. The patient might have orthostatic hypotension, or they could possibly be glycemic, hypoglycemic. The ability to maintain balance or equilibrium control is a complex function that requires accurate information from several sensory modalities listed here on this slide on the input side. The first is the visual system, the second is the vestibular system, and the third is your somatosensory system. The visual system provides an external reference telling the brain about the world outside. The vestibular system provides an internal reference telling the brain where the head is in space as well as the direction of movement. And finally, the somatosensory system is composed of the muscle receptors in the ankle and lower leg, and these provide an external reference from tactile contact with surfaces. Now, it's the job of the central nervous system to take information from these three sources of input and make sense of it. The resulting output, if all three of these systems are intact, is balance. However, if there's a problem with specifically the vestibular system, or there's some sort of conflict between any of these three systems in the brain input, then nausea as well as vertigo and nystagmus may result. Anytime a patient presents with vestibular dysfunction, always remember that this dysfunction can be due to the peripheral vestibular system or the central vestibular system. If it's peripheral in nature, then it may involve the vestibular apparatus or the vestibular portion of cranial nerve number 8. If the dysfunction is central in nature, then this involves vestibular nuclei as well as central pathways. Peripheral vestibular dysfunction can be classified as unilateral, or it also might be bilateral. The patient might present with reduced or hypofunction or absent function, and the dysfunction may be in the acute or chronic stage. Examples of peripheral diagnoses that you might see this summer include acoustic neuroma or other tumors that affect the cranial nerve root entry. Meniere's disease, we'll talk about Meniere's later on in the PowerPoint. One of the treatment for Meniere's disease is going to be a gentamicin otolithic ablation. Again, we'll talk about that later. It could be due to some sort of local trauma, head trauma. Could be Guillain-Barré at the cranial nerve 8 root entry. Could be BPPV, or it could be some sort of infection resulting in labyrinthitis or vestibular neuritis. Another possibility is something known as a perilymphatic fistula. The most common cause of vertigo is known as BPPV. This stands for benign paroxysmal positional vertigo, and I have heard that it's only considered benign if you're not the one that has it. The patient experiences brief episodes of vertigo that are precipitated by a rapid head movement. As I mentioned in BPPV, one of the diagnostic features is that the vertigo is brief. typically lasting anywhere from 30 seconds to 2 minutes. It's more common in females than males, and over time you can have spontaneous remission, but recurrences can occur. The pathophysiology of BPPV is quite simply that the otoconia from the utricle gets stuck in one of the semicircular canals. This is known as canalithiasis. It's more common to have posterior canalithiasis than lateral canalithiasis, simply because the posterior canal is posterior or inferior to the utricle and gravity happens. When the otoconia gets stuck in the semicircular canal, it creates a suction moment that distorts the ability of the crista ampullaris to detect head motion. That is why BPPV is known as a hyperfunction, because you're getting extra or hyper signal from the affected ear. In addition to canalithiasis, you can also have cupulolithiasis. This is where the otoconia gets stuck on the cupula, which is that gelatinous matrix that's part of the crista ampullaris. Okay, the only difference between canalithiasis and cupulolithiasis is that with cupulolithiasis, the nystagmus lasts for greater than 1 minute. With canalithiasis, it lasts for less than 1 minute. Fortunately, since BPPV is the most common cause of dizziness, the prognosis is very good. It will go away on its own within 6 to 12 months. In the case of BPPV, the anti-vertiginous drugs are ineffective. Examples of these anti-vertiginous drugs that you may come in contact with are known as antivert and or meclizine. Know that the elderly are going to respond more slowly as far as being completely cleared of dizziness. Now on to the second most common cause of vertigo, and this is known as vestibular neuritis. It has a probable viral etiology, similar to Bell's palsy, and sometimes epidemics of vestibular neuritis can occur in a particular area. It is often concurrent with or preceded by about 2 weeks by an upper respiratory or GI infection. Vestibular neuritis affects individuals primarily in the ages of 30 to 60 years old. The peak age in women is in their 40s, and the peak in men is in their 60s. It is characterized by the acute onset of prolonged severe rotational vertigo, which increases with movement of the head. It is associated with horizontal nystagmus, postural imbalance, as well as nausea and vomiting. The medical management for vestibular neuritis includes giving the patient vestibular suppressants such as antivert or meclizine. Patients should be on bed rest for 24 to 72 hours until the nausea and vomiting are depleted. Then the patient is gradually to return to function, expecting a total recovery in about 6 weeks' time. When the patient is stable and no longer experiencing severe nausea and vomiting, you should realize that vestibular rehab can significantly speed their recovery. In the case of the rehab, you want to slowly increase their ambulation, provide general conditioning exercises, as well as gaze stabilization exercises, and facilitate central compensation. We'll talk about what all of these things mean and effective programs for patients with vestibular neuritis during the lab portion of the class. Another common peripheral vestibular diagnosis you may hear about is called a perilymphatic fistula. With this diagnosis, there's actually a tear in the membrane separating the middle and inner ear. And I think you can see a pretty good picture of this on the right-hand side of the slide. Here you can see that the fluid leaks out and causes vertigo. It's actually caused by some sort of head trauma or a pressure change from diving in a deep water, flying, or weightlifting, and it could also be caused by infection. As far as prognosis for this perilymphatic fistula, it may heal on its own, and it might require bed rest to do so. Alternatively, it might need surgery. And if the patient has had surgery, they might need vestibular rehab
if they've developed a hypofunction due to the surgery. Note that if the patient has a perilymphatic fistula, vestibular rehab will not help them until that hole is fixed.
The last example of a peripheral vestibular diagnosis would be Meniere's disease. Meniere's can be either hereditary or sporadic. It's characterized by distension of the endolymphatic system with concomitant hair cell damage. Patients with Meniere's will complain of vestibular as well as auditory involvement. Patients with Meniere's, the vertigo usually lasts hours and is usually preceded by a feeling of ear fullness or pressure. There's also a change in tinnitus, or patients might report a change in tinnitus or ringing in the ears, and they usually have some sort of associated change in hearing function. The prognosis for Meniere's disease isn't as good as the others. There essentially is no cure. As far as medical management, patients are giving meds for their vertigo, diuretics to help with the feeling of fullness or the inflammation in the ear. They may be given middle ear injections such as gentamicin, which we talked previously about the gentamicin otolytic ablations. It essentially knocks out the function of that particular ear. They could also be given steroids and or surgery. Realize that once Meniere's patients are stable, then they can be good candidates for vestibular rehabilitation. And finally, in addition to the peripheral vestibular dysfunction, you should realize that there are also central vestibular diagnoses to be aware of. We'll talk about the differentiation of these central versus peripheral in another PowerPoint slide, as well as the lab portion of the class. Examples of central dysfunction could include a TBI, a CVA, multiple sclerosis, a tumor, patient with meningitis, as well as a patient with hydrocephalus. And it's an important job of the physical therapist when given the script of treat for dizziness to be able to determine whether the patient shows signs of peripheral dysfunction or central dysfunction. If there are central dysfunctions that aren't previously recognized by the medical profession, then the patients need to be referred back to the physician for a diagnostic workup.